All right. So thank you all for joining. I'm going to be speaking today about investigating risk in chronic traumatic encephalopathy. This encompasses some of work from a few years ago, and then brings in some of the new work that we're doing as well. I did give a similar talk to the precision medicine group. So if you attended that as well, this could be some overlap, but I've also tried to incorporate something new. All right. All right. So here is the outline. I'll do a brief overview of CTE for those that are a little less familiar. Then we'll spend some time talking about definitions, specifically concussion, subconcussion, repetitive head impact exposure. Getting the definitions down and clear makes a lot of difference when thinking about these concepts. So then I'll talk about football. We have a lot of data on football, so I'll walk through some of the data. I'll also talk about some of the other exposures, contact sports, as well as there is some new, there was a recent paper in the New England Journal on military exposure as well. And we'll talk a bit about other pathologies related to repetitive head impacts. We had a recent paper published on ApoE, so I'm also going to talk a bit about that paper and why I think genetics is important for CTE. And then I'm hoping to get to some of the new and ongoing projects. I often don't get to that when I give this lecture, and I think they're interesting and neat. So hopefully I cut back on some of the other slides and we'll talk about the new things. All right, so CTE is not a new disease. It was first described by Harrison Martland in 1928. He called it punch drunk. Nearly half of the fighters who have stayed in the game long enough. This was specifically about boxers, not about other types of contact sport athletes. So even though this disease has gotten a lot of attention recently and seems newly described, it's not. I learned about it in medical school, used the term dementia pugilistica. So it's been described for a long time, though thought to be incredibly rare. The term chronic traumatic encephalopathy was first coined in 1949 by Critchley. So the CTE is a neuropathological diagnosis, and the pathognomonic lesion, so the lesion that we see in CTE, but not in any other type of disease or neurodegenerative disease, is these tau lesions, neurofibrillary tangles in the cortex surrounding blood vessels. They typically are at the depth of the sulci. You can see various images here of these lesions. They're stained here with tau antibody AT8. This lesion was first recognized prior to Anne, Dr. McKee, but she has really been the leader in terms of recognizing that this is a pathognomonic lesion not seen elsewhere. And there's been a lot of effort to refine these criteria further, saying that the tau pathology needs to be in neurons, and bringing the entire research community along, working with several different neuropathologists from various other universities who have expertise in tauopathies, to recognize that this is a unique pathognomonic lesion. All right, so we also have a staging scheme for CTE, stage 1 to stage 4. The pathology tends to begin in the frontal lobe, most commonly the dorsolateral frontal lobe, and then spreads to involve other cortical regions, superior temporal, inferior parietal in stage 2. By stage 3, there is involvement of medial temporal structures and the hippocampus. And by stage 4, there is widespread pathology. This spread of tau pathology is different from Alzheimer's disease that tends to begin in the brainstem, involve the locus ceruleus, and then spread to the medial temporal lobes, and then last to the cortex. And you can see the median age from our brain bank of these different stages. So each stage seems to correlate with age, seeing stage 1 in 30-year-olds and stage 4 on average in 70-year-olds. So clinically, just to give you a sense of what the syndrome looks like in life, most of the data that we have collected has been retrospective, interviewing family members of deceased individuals who have the pathology to get a sense of their clinical information. Dr. McKee has led our brain bank efforts now with over 1,200 former contact sport athletes in the brain bank. This is one very classic case of an individual I interviewed the family members from several years ago now, and it just gives a nice flavor of the clinical presentation. So this was a former NFL player. He had played for 17 years, 6 years in the NFL. He was a center. His family reported 50 concussions after we read them a definition of concussion, and we'll talk more about these definitions in a few minutes. One with brief loss of consciousness. He was never hospitalized. His clinical course, he began having angry outbursts in his late 20s. By his mid-50s, he had mild memory impairment, but continued to work as a sheriff. Interestingly, he won several elections to be sheriff. He retired at age 64 after losing an election. At the time, he was experiencing apathy, depression, anxiety. By his mid-60s, there was progression on multiple fronts. He had more memory impairment, more angry outbursts. He was also having navigational difficulties, language problems, motor symptoms, gait instability, decreased facial expression, and some mild impairments in instrumental daily activities, so functional impairment. And he died not related to his cognitive and mood and behavior difficulties, but due to a heart attack. And we bring all of these cases to a consensus conference where the clinicians make a diagnosis of what we think was happening in life and what we think the pathology is. I have a whole separate talk on that whole process and our traumatic encephalopathy syndrome criteria. But for the purposes of this talk, I think this is just a very classic case where you're seeing symptoms, particularly in the early relative to Alzheimer's disease, but mid-50s, starting with mood and behavior symptoms as well as cognitive symptoms. These angry outbursts, behavioral dysregulation is a term that we've been using, is one feature. And then from a cognitive standpoint, we see memory as well as executive function impairments. So we thought this case was really classic. The exposure was overwhelming, and the consensus team thought it was CTE in life. And neuropathologically, we were in agreement. This was stage 4 of 4. You can see some of the lesions here. There was no other comorbid neuropathology, so no A beta, no TDP43, no alpha synuclein. All right, so for the rest of the time, so that's kind of an overview of CTE and what it looks like clinically and neuropathologically. For the rest of the time, I'm going to talk about risk and how we understand risk for this disease, what we know, what we don't know. And I'll start with some definitions to help clarify. So this is a definition that we read to all of our informants in the brain bank before we ask them how many concussions we think their loved one experienced. And I'm not going to read the whole definition here, but what it basically says is if there is a blow to the head and there are any symptoms, and you can see the long list of symptoms here. So blurred or double vision, seeing stars, getting a ding, your bell rung, all of that is a concussion. So, you know, any symptoms, not just loss of consciousness or not just days of symptoms of going on for a while after. So that is in contrast to a subconcussive injury or a non-concussive injury, which is an alternative term which there's been some effort to use instead. And this is a blow to the head resulting in a brain injury that does not manifest symptoms. So this would be somebody who gets hit, who has biological changes in their brain, but who doesn't experience any symptoms at the time. You could think of this similarly to somebody who is smoking cigarettes and is having injury to their lung epithelium. They aren't having any symptoms at the time. They might even be enjoying it, but there is still injury to the cells. This non-concussive injury term rather than subconcussive is to drive home the point that these are still important, even though they are not symptomatic. And in fact, I'm going to talk a little bit about some of our helmet sensor data. And what we've seen is that some of the force needed to cause a concussion can be nearly identical to the force when somebody doesn't suffer any symptoms at all at the time. So by using subconcussive, it's suggesting that it's less important, while non, I guess, suggests that it's just there aren't symptoms at the time. But I think it's also important to think about and what we've seen is that these kind of subconcussive injuries are what's most associated with CTE, and I'll talk more about that in a few minutes. But it makes a lot of sense that you don't necessarily need to have symptoms at the time of this blow to your head in order to develop a neurodegenerative disease years and years later. So, and then this is in contrast to repetitive head impact exposure. So this is kind of getting at epidemiological concepts where we talk about being exposed to something and then having an outcome related to that exposure. Whether you're suffering an injury is separate from whether you're having that exposure. So you might be having these repeated blows, but not having any biological changes or symptoms. But these repetitive head impacts are much easier to assess and measure than whether there's actually changes going on in the brain. So we tend to use RHI as a proxy for the subconcussive injury. All right. So then how does symptomatic TBI fit in with CTE? I did talk about this a bit. So symptomatic TBI or concussion, those are synonymous, has long been considered one of the strongest environmental risk factors for dementia, though the strength and stability of this association is inconsistent across studies. And the relationship in these types of mostly epidemiological studies of the living have shown that moderate to severe TBI, so these are individuals who have loss of consciousness for 30 minutes, or who have changes on their MRI and blood, evidence of blood, et cetera, or really extended symptoms and amnestic period. These moderate to severe TBIs have been more strongly associated with dementia to date, even though they're far less common than the mild TBIs or concussion. And these associations have largely been with dementia. And then it's important to remember that dementia is a clinical syndrome with many different neuropathological etiologies: Alzheimer's disease, Lewy body disease, vascular disease, frontotemporal dementia, as well as CTE. And it's very possible that different types of exposures, different types of traumatic brain injuries could be differentially related to different pathologies. And then, so unlike all of these other neurodegenerative diseases, CTE has nearly exclusively been described in the setting of head trauma. And then this relationship has been with this RHI, so repeated head impacts, not symptomatic TBI. And we'll talk more about all of the data getting to this point. But these are concepts that I think are really important to distinguish, and when we talk about the next pieces to help clear. So here is a breakdown. It's a couple months old at this point of individuals we've assessed in the brain bank. And in order to be eligible for the brain bank, you need to have exposure to repetitive head impacts in the form of contact sports or military service, intimate partner violence. You can see we've here had over 1,100 evaluated. The number of donors is now over 1,200. So not all of them have been evaluated, and the slide is a couple months out of date. But you can see that CTE is common across many different exposures. Most of the brain bank is American football players, but we've seen CTE in boxers, ice hockey players, rugby players, as well as some military veterans who have not had contact sport exposure. Interestingly, what we see this giant overlap between military veterans and those who have also played contact sports, so it's hard to disentangle. Another important point to talk about here is that while the criteria to get in the brain bank and it has nothing to do with the symptoms that the individual was having during life. It's only based on the exposure. That being said, individuals who were having symptoms, their families were more concerned, are more likely to donate. So we see these really high levels of CTE. We can't say that these are the frequencies that we would see in the general population of those exposed to repetitive head impacts. But we are seeing that this pathology seems to be quite common among these individuals with a lot of exposure. Most of the athletes are elite athletes who played high-level amateur or professional, but not exclusively. And we've certainly seen the pathology in lower-level exposure too, and I'll talk more about that. So this is a really nice paper from Kevin Bianek from now several years ago, but it drives home the point really clearly how important repetitive head impact exposure is to CTE. So at the time he was working at in the Mayo Clinic brain bank, and that's led by Dennis Dixon. They have a particularly large brain bank. It's not representative of the general population, but it is very representative of neurodegenerative disease. So he looked at they started with over 4,000 brains. He looked specifically at the men, so about 50% of that. They ruled out, they did not look at individuals with other types of primary tauopathies, but among the rest, they reviewed death records and high school yearbooks to find evidence of contact sport play. And among those 1,700, they found 66 who had played contact sports, and they reviewed those cases carefully for evidence of CTE. And they found that about a third of them, 21, had CTE pathology. They then looked at a matched group of men who were not contact sport athletes. So a 2-to-1 match, 132. And they found that none of them had CTE. They similarly looked at women, 66 women, none of whom had CTE. They also looked at 33 brain donors with a history of single TBI, none of whom had CTE. So this type of breakdown of CTE in those with contact sports versus those without, very unlikely to be due to chance. Very small p-value. So this is a really nice study, early study linking contact sports to CTE. So this is our case series from 2017, where we looked at 202 football players from our brain bank. And we looked at several things here, including the symptoms, but what I'm really trying to drive home here is that what we saw is that as level of play increased, the frequency of CTE also increased. So 21% of the high school players, 91% of the college players, 110 out of 111 NFL players. So this was an incredibly high frequency. This is getting back to the point that I made early on. This is not what the frequency is among NFL players who are living. We have this selection bias, but nonetheless, it's an incredibly high, striking number. Similarly, we saw increasing rates of CTE with increasing severity of CTE among those with CTE as level of exposure increased. So you can see 86% of the NFL players had severe CTE stages 3 or 4 versus 56% of the college players. So based on this, we hypothesized that duration of play would be particularly important as a risk factor for CTE. And we looked at this among 266 brain donors, 43 without CTE, 78 with mild, 145 with severe. Again, we looked just at American football players so that we would have a more homogeneous measure of exposure. And what we found was that the odds of CTE increased by 30% for each additional year played. And that equates to doubling of odds every 2.6 years. And this was highly significant. And then similarly, among those with CTE, the odds of developing severe pathology increased by 14% for each additional year played. And this is equivalent to doubling of odds every 5.3 years. And we were also really interested in predicting when the pathology would be there from a clinical standpoint. And there's a general rule of thumb that if a positive likelihood ratio is greater than 10 or a negative likelihood ratio is less than 0.1, then we can then that can change clinical decision making. So we did a ROC analysis, and we found cut points that corresponded to those likelihood ratios. So we found that individuals who played, football players who played fewer than 4.5 years were 10 times less likely, or a likelihood ratio of 0.1 to develop CTE relative to those who played more than 4.5 years. And similarly, individuals who played 14.5 years were 10 times more likely to develop CTE than those who played fewer than 14.5 years. And we were able to maximize the sensitivity and specificity at 11 years. So a big piece of whether these are important findings at all is whether this can generalize to all football players, not just those in the brain bank. I've already mentioned multiple times how we think there's this selection pressure, that more folks in our brain bank have CTE than what is likely in the general population of football players. And this, and so this can be diagrammed out with this image that you see here. We're really interested in how years of football play is related to CTE status. And the only way that selection might bias this relationship is if years of football play is related to selection differentially than the way that CTE status is related to selection. So if we knew how much football people in the general population of football players played, and we knew how common CTE was in the general population of football players, then we could use some causal inference type of approaches to adjust for this selection bias. But unfortunately, we don't know either of these things. We don't have a good sense of how many years people have played football, those who have played football played. We looked pretty hard. We couldn't find this anywhere. And similarly, we don't have any sense of how common CTE is among football players. So what we did instead was a simulation study where we looked at every reasonable relationship between years of football play and selection and CTE disease status and selection. And what we found is that across all of those settings, there was never a time when years of football play was not still associated with CTE disease status. So even in the most extreme settings, when for each additional year played, somebody with CTE was 50 times more likely to donate their brain. Even in that setting, we saw a very similar relationship. So I think we can say with relative clarity that this relationship is true, and that we're seeing this dose-response relationship. So some of the things that we did, we also looked at. So we also looked at concussion number based on that definition that we read to all of the informants. And we also looked at age of first exposure to football. We looked at whether other contact sports were played. We looked at different football positions, and in none of these settings were we able to find any relationships with CTE. And a really important limitation, which I already really got at, was that we can't, from these findings, we can't talk about the probability of CTE in the general population. We can just talk about these relative measures. For each additional year, the risk increases, the odds increase. But these cut points that we proposed were really important for developing new criteria to diagnose CTE in life. Something that we call traumatic encephalopathy syndrome. This paper was led by Doug Katz at BU. Senior author is Bob Stern. And what we incorporated in was these levels of certainty of CTE pathology, and it's based on several factors, but the data from that paper and those cut points were incorporated as part of the probability calculation. All right, so to take this a step further, this is work that we recently published from Jessica Leclerc, who is a PhD student in biostatistics with Yorgos Tripodis. And this is a really nice paper at getting at some of the limitations that we saw in that 2019 paper. So in that paper, we couldn't talk about what was the absolute risk of CTE because we didn't have a good sense of how much football the general population of football players played based on duration of play, years of play. But we do know how many high school players there are a year, and we know how many college players there are a year, and how many professional players there are a year. And we also know at least approximately their rate of death of each level. And so we can estimate the minimum number of CTE cases in the general population by level of play, here by assuming that only the folks in the brain bank have CTE, and all of the others who have passed away who weren't in the brain bank did not have CTE. So obviously this is likely much lower than what the actual number is for lifetime cumulative incidence, but it does give us a minimum threshold. And you can see these numbers here. At minimum, 10 or 11% of the professional players seem to have what we would expect to have this disease at death, likely a lot higher. 0.3% of the college players, high school players, quite infrequent. But we can use this information further to get a sense of risk by level of play. And when we just do the analysis among those in the brain bank, we see that the college players are 82% more likely to develop CTE, the professional players, compared with the high school players, and the professional players 2.13 times as likely to develop CTE compared to the high school players. But then when you start to incorporate this additional selection data that we know, so how many individuals are playing the disease, playing the sport at each of the levels, what's the rate of death, we can further make estimates about what we think these relationships would be in the general population of football players. And what we actually found was that these risks increased. We would expect these risks to increase relative to what we saw in the brain bank. So for college players, 2.38 times as likely, and for professional players, 2.47 times as likely. And we think that the reason that these numbers are actually lower in the brain bank than what it is in the general population of football players is because we have a massive differential in terms of donation of individuals who played at the high school level and who did not have CTE in life. And because of that, we are actually underestimating these relationships once you do the math. I actually think that these estimates that we're seeing here are a little bit difficult because we have so few high school players who don't have CTE in the brain bank. But it does start to get at what is the absolute number in the general population, and and what are these relative measures, something that we can't do as much with duration of play. All right, so can we do better than years of play or level of play at predicting CTE? So this is a paper from Phil Montenegro, who is an MD-PhD student with Bob Stern from a couple of years ago, where we leveraged helmet sensor data to make better predictions. This was in in a living sample, but we've now recently extended this approach to the brain bank as well. And the way that this works is we did a literature review of helmet sensor data in youth, high school, and college football players. So from this, we are able to get a count of the average number of hits that a youth player, high school player, or college football player experiences over the course of a single season. And we can create this positional exposure matrix of these impact frequencies by level of play and by position. And then we can extrapolate that data to our study participants. So ideally, we would have this actual helmet sensor data from our participants or from our brain donors, but realistically, that's never going to happen. So this is a way of using the data that's in the literature to make assumptions and estimates about our study participants. So from this this positional exposure matrix, we can generate the CHI, or the cumulative head impact index, which is a measure of the number of impacts that the participant on average experienced over the course of his career. So it's, in a sense, summing up all of the hits for each year based on his level of play and position of play. And what we found was that this measure of this CHI was associated with several clinical outcomes, including behavioral dysregulation, executive function, depression, apathy, and a global measure. And at the time of this paper, there were five papers in the literature that we were able to use that had helmet sensor data that we used to extrapolate. But there has been an explosion of this data since then, such that now for this paper that we currently have under review with Dan Danishavar, there are now 34 helmet sensor studies. And we've now extended this not just to the living participants, but also to our brain donors. And we've expanded this positional exposure matrix to these 34 published helmet sensor studies. And the other thing that we get from these helmet sensors, in addition to the number of hits, is the amount of force, either the linear acceleration or the rotational acceleration that each impact exerts. So we can incorporate that into our extrapolation and our estimates as well. So here you can see the 631 individual brain donors, football players that we used in this current study. You can see a picture of the helmet sensors at the bottom there. And we generated the CHI, which is the measure of the hits over the course of their career. And we also were able to generate the amount of linear force that they experienced over the course of their career and the amount of rotational force that they experienced over the course of their year. So if they had tens of thousands of hits over their career, and on average, each hit was 25 Gs, then you can sum up those 25 Gs over those total number of hits. And you get this measure, which we call chi-G, and similarly chi-R. And what we found was that when we compare to duration of play, the chi-g, so the total linear force, as well as the chi-r, the total rotational force, was significantly better at predicting CTE pathology than just duration of play. Interestingly, when we compared the hits, the chi, the original measure that we had, we did not see any improvement over duration of play. And we looked at this across a lot of different either model fit or predicting CTE status, and we saw this improvement. Similarly, when we looked at CTE severity, we saw that the chi-g and the chi-r outperformed the chi as well as duration of play, but we saw no improvement with just the hits. So this starts to argue that it's not just the number of hits, but how hard those hits are. But you really need to incorporate the intensity of hits, the number of hits, and the length of the individual's career to really get a better estimate than what just duration of play gets you alone. We also looked in this paper at position in several different ways, given that position is key for this positional exposure matrix. And when you just look at position, we again, like the earlier paper, weren't able to see any relationship. All right. So moving on from football to other sports. So this is a really nice paper that was in New England Journal a couple of years ago from Willie Stewart's group in Scotland, where this is a living epidemiological study. So we don't have measures of the neuropathology, but they looked at over 7,000 former professional soccer players and over 23,000 matched controls. And they performed Cox proportional hazards, looked at time to death. And what they found was, not surprisingly, that these professional soccer players were less likely to die, from heart disease, and were less likely to die from lung cancer. But interestingly, were 4 times more likely to die from neurodegenerative disease compared to their matched controls. And these low hazard ratios are likely the effect of the healthy worker effect. These are healthy individuals. They're less likely to have heart disease. They're less likely to have lung cancer. But interestingly, they were 4 times more likely to die from neurodegenerative disease. So it's a really striking finding. And then also interestingly, when we look at this hazards of death by age group of these former professional soccer players, we see that the hazards is reduced for 40-year-olds, for 50-year-olds, for 60-year-olds. At 70, their hazards is equivalent to the general population, and then by 80 and 90, it's increased. So providing even more data that the playing soccer, presumably the head impacts are leading to increased risk for neurodegenerative death. We've now begun to do similar analyses like we did in the football players and in the hockey players. We now have 70 plus hockey players who have donated to the brain bank. And we've also grabbed some hockey players from the Framingham Heart Study brain bank too. And we're seeing very similar relationships here with each additional year played, increasing odds of CTE. For the hockey players as well, also for CTE severity. Also here we have another measure of tau burden. So we presented this at this year's AAN. We're hoping to get this paper out. We're doing a similar simulation analysis to look at selection bias. And then going beyond contact sports to military, this is a paper that came out this summer from Dan Pearl's group, where they looked at 225 consecutive brain donors who all were served in the military. And folks in the military may have had repetitive head impacts, they may not. Some of them sit at a desk. Some of them undergo basic training, combatant training, things like that. But this group was not selected for only individuals who had had that exposure. This was all military decedents. And what they found was that of these 225, 10 had CTE. And sort of the one-liner that came out is, look, CTE is rare among the military. But still, I think in any other setting, if you were finding 4% having a neurodegenerative disease or having any disease, it would still certainly be a concern. And then when you look at their different types of traumatic brain injuries and other head impact exposures, you see that all 10 had a history of contact sports. So it's really difficult to disentangle what's really leading to this disease in this setting, because contact sports and participation in the military are so closely intertwined. All right. So then, in addition to CTE, we've also shown, particularly Torstein, Michael Osko had a really nice paper. Dan Danishvar also had a really nice paper showing that contact sports, repetitive head impacts are also related to other types of neurodegenerative outcomes, including cerebral amyloid angiopathy, Lewy body disease, ALS, white matter changes. So this relationship doesn't seem to be specific to CTE pathology. I think that the major difference is that CTE we're almost exclusively seeing, or entirely exclusively seeing, in the setting of repetitive head impacts. These other pathologies obviously occur outside of that setting, but the risk of having them increases with the repetitive head impacts. So what about genetics? This is a particular interest of mine as well. And these two cases, PC and MK, both from our brain bank, demonstrate really clearly why genetics may also be playing a role. So these were two brain donors, young individuals, 28 and 25, who were very similar. So they played similar amounts of football, 17 years versus 16 years. They played the same position, linebacker and special teams. PC essentially had minimal or very mild symptoms, behavior, cognitive symptoms beginning in his mid-20s. You know, if you didn't probe substantially, you probably wouldn't notice anything was abnormal at all. While MK had really substantial mood, behavior, and cognitive symptoms beginning in college. He did well in high school. He never finished college, and he had a lot of difficulty finding any work after college. And PC had no evidence of CTE, but didn't have a normal brain, still had isolated neurofibrillary tangles, which you really should not see in a 20-something-year-old. MK, on the other hand, had stage 2 CTE. You can see some of his images to the right, despite only being 25 years old. So these are two individuals with very similar exposures, who have substantially different pathology. So it suggests that other risk factors, potentially genetic risk factors, could be driving differences in CTE pathology. So why should we study genetic risk in CTE? It may increase, it may help us understand etiology and biology. It may aid in counseling contact sport athletes about their risks. It may provide targets for disease-modifying drugs. So we've looked at several genes. I'm going to focus on ApoE here for time's sake, and because this is a new paper, which I think is pretty striking. So ApoE, this is an Alzheimer's audience. We all know about ApoE. It codes for the primary cholesterol transporter in the brain. There are 3 alleles determined by 2 SNPs. It confers the greatest genetic risk for sporadic AD. E2 confers protection. We've known about it for many years in relationship to AD. We also know that it's a risk factor for other neurodegenerative diseases, as well as other vascular diseases. What we've also learned about Alzheimer's disease is that E4 seems to confer different risk with age. So there was a recent meta-analysis that showed that the risk was strongest in like 50 to 70-year-olds, and the risk was lower in those younger than 50 and older than 70, or approximately that. And there's also data that that E4 carriers may actually do better cognitively in young individuals. So these differences by age are really important for the current study, and that's why I bring it up. E4 has also been implicated as having worse outcomes from TBI. There's also been some literature suggesting that the relationship between TBI and Alzheimer's disease may be moderated by ApoE4. We had looked preliminarily at ApoE4 in previous studies, but they were limited by sample size. So Bob Stern's study only had 68 individuals without controls. So we ended up looking at the general population. Torstein had a paper several years ago that indirectly looked at the relationship. But this current study was meant to overcome some of those limitations. And we had 364 individuals, 70 controls, and then 294 with CTE, spanning the different CTE stages. The median age was 65, 15% were self-reported Black race, about 50% had dementia. And what we found was that among those less than 65, we found no significant relationships with any of the outcomes that we were looking at. But among those above 65, we saw no relationship with CTE status, so CTE yes versus no. But we did see these strong relationships with CTE stage, with dementia status, as well as a measure of quantitative tau burden. This last measure is not an odds ratio, so it's still significant here. And interestingly, when we excluded individuals who also had AD or had AD but not CTE, we saw very similar effect sizes. We saw the strongest effects when we looked at semi-quantitative measures in different regions of the cortex, particularly the regions that are most affected by CTE, the dorsolateral frontal, inferior parietal, superior temporal. We also saw an effect in the amygdala. Interestingly, we didn't see an effect in the hippocampus, despite the fact that, at least in Alzheimer's disease, E4 carriers tend to have disproportionate amounts of hippocampal pathology relative to cortical pathology. We also did this analysis specifically among the football players, and we were able in this setting to compare the effect of E4 to the amount of football played, getting at the duration of play findings that we talked about before. And what we found was that among the football players, the E4 association with CTE stage was similar to playing more than 7 years of football. So we're really starting to get at kind of this precision medicine approach, where it seems like the exposure to football is particularly important for getting the disease, but other factors might be driving how severe the disease is, and whether folks are getting dementia, and that could be ApoE4. In other analyses, we also adjusted for amyloid pathology, and we did see, not surprisingly, some reduction in effect sizes when we adjusted for neuritic plaque and diffuse plaques. But even after adjusting for those, we still saw significant direct relationships between ApoE4 and CTE pathology. We did not see an association with E2. We did not see any interactions with duration of play and E4. The associations were largely consistent when we limited them to just self-report white race. We were underpowered to look at self-reported Black race. And we didn't have any ancestry informative markers to look at population substructure. So I think, again, I'm not going to have time to talk about the new stuff, but this is an overall summary of kind of how we think these relationships exist. So we think that the repetitive head impacts are really crucial for developing this disease, but other risk factors are really important for modifying the risk and the severity. And then we think that these exposures are directly related to the pathology. The pathology is directly related to the clinical symptoms, and these other things, genetics, lifestyle, psychosocial factors, are probably modifying these relationships at all levels. So I think with that, given the time, I'm going to stop and I can stick around for questions.
Thank you, Jesse, for doing our presentation today. Again, if anyone has questions, please feel free to ask now, or you can put it in the chat.
Okay.